All right, class, settle down, settle down. Chalo, let's begin today's very, very important topic. Many of you probably think of the skeleton as just some dry, dead frame to hang our bodies on. But I am telling you, you could not be more wrong. So let me ask you this question right away. Is bone a dead scaffold, or is it a living, breathing organ? Well, the truth is, your skeleton is one of the most dynamic tissues in your entire body. It is constantly changing, constantly responding, and rebuilding itself from the inside out. Now look at this number, 10%. You might think, okay, 10%, so what? No, this is huge. Every single year, 10% of your entire adult skeleton is completely torn down and rebuilt from scratch. It's like a massive continuous renovation project happening inside you. So the bones you have right now, they are not the same bones you had 10 years ago. It's amazing, isn't it? Okay, so let's get into it. Here's our little roadmap for today's session. First, we'll cover the basics of our living skeleton. Then we'll meet the amazing cellular team responsible for all this work. We'll understand their whole process, and then we'll see what happens when this process goes wrong, both genetically and metabolically. And of course, at the end, the key takeaways for your exams, so pay attention. So, section 1. Let's really establish this fundamental concept, the absolute bedrock of our topic today. Your bones are a complex, living framework. So please forget this idea of some inert scaffolding. It is a true organ system. And its functions are so much more than just holding you upright. Of course, it gives you mechanical support, it protects your vital organs, but it's also your body's primary bank for minerals. I mean, a staggering 99% of your body's calcium is stored right here. And, as if that's not enough, it's the factory where all your blood cells are made, a process we call hematopoiesis. Very, very important stuff. Now, the bone matrix itself comes in two main types. On the left, we have what's called woven bone. Think of it like a quick, messy patch-up job. The collagen fibers are all over the place, it's weak. But on the right, you see lamellar bone. This is the good stuff. Strong, beautifully organized, with collagen fibers laid down in parallel sheets. It's produced slowly and carefully. And here's the crucial point. Listen up. In an adult, woven bone is always abnormal. Always. So who is responsible for all this building and breaking down? Well, let's meet the cellular crew, the team that is working 24/7 inside your bones. First up, we have the osteoblasts. Just think of them as the construction workers, the builders. You'll find them on the bone surface, and their job is to lay down the new organic matrix, which we call osteoid, and then they control how it gets mineralized into hard, strong bone. But you can't just build something new without clearing the old stuff first, right? For that, we have the osteoclasts. These are the demolition crew. They're these huge, powerful cells that latch onto the bone surface and secrete acid and enzymes to just dissolve the old bone, carving out these little pits. Dekho bachcho, look at these slides. See on the left? You can see the builders, those nice plump osteoblasts, all lined up and laying down that new pink matrix. And on the right, see that giant cell with multiple nuclei? That's your osteoclast, the demolition crew, busy at work carving out the old bone. It's a beautiful dance of creation and destruction, really. And who's in charge of this whole operation? Well, those are the site managers. Of course, these are the osteocytes. They are actually former osteoblasts that got trapped inside the very matrix they were building. From their little pockets, they form this vast communication network, sensing mechanical stress, like from exercise, and telling the builders and the demolition crew exactly where they need to work. They're the brains of the operation. So, we've met the team. The builders, the demolition crew, and the site managers. Now let's see how they work together in this complete remodeling cycle. It is this constant, coordinated dance that keeps our skeleton strong and healthy. Now listen very carefully. This next part is the funda, the fundamental principle you absolutely must understand. If you get this, you will understand most of bone pathology. I promise you. The whole show is run by a very delicate balance in one key signaling pathway. This pathway is called the RANK-L-OPG system. Think of it like a car's accelerator and brake. The osteoblasts, the builders, they produce a signal called RANK-L. This is the accelerator, the go signal. It tells baby osteoclasts to grow up and start demolishing bone. But the builders also produce another molecule called OPG. This is the brake, the stop signal. It literally blocks RANK-L. So it all comes down to the balance between the go signal and the stop signal. That's what determines whether you build bone or you break it down. Simple as that. All right. So what happens when the genetic blueprint for making bone is faulty right from the very start? Well, this leads us to what we call developmental disorders. First, we have osteogenesis imperfecta. You've probably heard it called brittle bone disease. This is a group of inherited disorders where the problem is with type 1 collagen, the main protein, the rebar of your bone matrix. It's like trying to build a house with bad bricks. The fundamental problem is you simply have too little bone, and whatever bone you do have is incredibly fragile. And this tragically illustrates the devastating result. This is an X-ray of a fetus with the most severe form of OI. You can just see fractures in nearly every single bone. The limbs are shortened almost like an accordion because of these constant breaks happening even in the womb. Now let's look at the complete opposite problem, osteopetrosis, also called marble bone disease. Here, the genetic defect is in the osteoclasts. The demolition crew is on strike. They can't resorb bone properly. So what happens? Old bone never gets cleared away, and the skeleton becomes incredibly dense. Just look at this X-ray. The bones are chalky white, completely solid-looking, almost like stone. But here's the paradox. Even though they are so dense, they're also incredibly brittle. Why? Well, because that normal remodeling process that replaces old, tired bone with new, strong bone, it's just not happening. The bone is dense, yes, but it's poor quality, disorganized bone. Okay, so those were diseases from a faulty blueprint. Now let's shift gears and look at diseases that happen later in life, when the maintenance system starts to fail. These are the metabolic bone diseases. And the most famous one, of course, is osteoporosis. Now, this is not a problem with the quality of the bone matrix itself. The bone is mineralized just fine. The problem is there just isn't enough of it. Over many years, that balance of remodeling tips so that you are resorbing just a little more bone than you are forming year after year after year. Look here. This comparison, it says it all. On the left, a healthy vertebra with a thick outer cortex and a strong interconnected web of internal bone. Now look at the right, the osteoporotic vertebra. Can you see how the cortex is paper thin? And inside, those horizontal supports are completely gone? The entire structure is weak, just waiting to collapse under normal body weight. All right, Shallow, final summary. Listen carefully. These are the points you must remember. 1. Bone is alive, constantly remodeled by our builders and our demolition crew. 2. Everything is controlled by the balance between the rank L go signal and the OPG stop signal. 3. Osteogenesis imperfecta, bad bricks, which means too little bone. 4. Osteopetrosis, demolition crew on strike, making bone dense but brittle. And finally, number 5, osteoporosis is a slow, silent loss of good bone over time, which leads to weakness. Got it? Good. And that brings us to the end. I'll just leave you with one final thought. We now know that your skeleton is constantly rebuilding itself, right? It's responding to the demands you place on it. So my question to you is this. Knowing this, what is one thing you can do today, right now, to give your builders and managers the right signals to build a stronger skeleton for your future self? Think about it. Class dismissed. All right, everyone, cello, let's begin. Now tell me, when I say bone problem, what's the first thing that pops into your head? A fracture? Henna? A simple break. But you know, our skeletal system can fail in so many other ways, much more complex, and frankly, much more interesting. So today, we're going way beyond this simple break. We're diving deep into the intricate diseases that can plague our very bones. So this is a main question for today. How else can they fail? See, it's very easy to think of our bones as just hard, lifeless pillars, like the frame of a building. But that's bilkul wrong. They are incredibly alive. They are constantly breaking down old bits and building up new bits in a process we call remodeling. And this dynamic nature, this constant activity, that is also their biggest weakness. Because you see, they can be attacked from the inside by our own haywire chemistry, they can be invaded by nasty bacteria, or they can even be betrayed by their own cells, which suddenly decide to multiply out of control. So, first up, let's look at what happens when the body's own system turns on itself. We're going to explore metabolic bone diseases. Basically, these are conditions where that delicate chemical balance that keeps our bones strong is thrown into complete chaos, and the results can be pretty catastrophic. Okay, let's start with this big one, renal osteodystrophy. I know, it's a very heavy-sounding name, but the concept behind it is actually a simple and quite devastating chain reaction. Just think of it like this. When the kidneys fail, they can't manage the body's accounts of calcium and phosphate anymore. The whole system goes into a panic. The body then basically issues an order to start looting the main calcium bank, which is your bones. What you get is a whole collection of skeletal problems. It's a perfect tragic example of how trouble in one organ can launch an all-out war on the skeleton. Now for a very peculiar condition, Paget's disease. I want you to imagine a construction crew that has suddenly gone completely mad. They start throwing up bricks and cement everywhere, working super fast. From a distance, the wall they build looks very thick, no? But when you get closer, you see it's a total mess, completely disorganized and structurally weak, ready to collapse at any moment. That, my friends, is essentially what happens in Paget's disease. There's a ton of new bone being formed, but it's all wrong. It's just not sound. The story of this disease unfolds in 3 acts. Act 1 is the osteolytic phase. This is pure destruction, where the bone-destroying cells, the osteoclasts, just go into a frenzy. That's followed by Act 2, the mixed phase. This is pure chaos, with frantic destruction and messy rebuilding happening at the exact same time. And finally, in Act 3, the whole process just burns out. You're left with bone that is thick and dense, what we call sclerotic, but it's brittle, like old glass, and dangerously prone to fracture. Ah, now this is the money shot. What you see here, under the microscope, is the absolute hallmark of Paget's disease. It's called a mosaic pattern. You can see these prominent cement lines fitting together haphazardly. It literally looks like a jigsaw puzzle that a small child put together. The pieces don't quite fit, right? This picture beautifully shows the structural weakness. Even though the individual pieces are strong lamellar bone, because they're all stuck together in this chaotic way, the overall strength of the bone is totally gone. All right, let's shift gears now. We've talked about these internal metabolic problems. Now, let's focus on external threats. We're going to talk about things that attack the bone from the outside, like interruptions in the blood supply, and of course, infections, the bugs. Osteonecrosis. You know, the name says it all. Osteo for bone and necrosis for death. Bone death. It's as simple as that. A piece of bone tissue dies simply because its blood supply gets cut off. The best way to think about it is like a heart attack, but it's happening inside your bone. Now, this can be caused by trauma, of course, that physically cuts a blood vessel, but it can also be caused by things like long-term steroid use, which can clog up those tiny vessels. And this image shows you the consequence perfectly. What you are looking at is the head of a femur, the thigh bone. See that pale, wedge-shaped area right under the cartilage? That is dead bone. That's the infarct. Now, because this dead segment can no longer support the weight of the body, eventually, crack, it will collapse. This leads to the total destruction of the joint surface, causing severe, painful secondary osteoarthritis. Next up is osteomyelitis. In simple terms, this is an infection of the bone, and the most common culprit, the #1 bad guy, is usually our old friend Staphylococcus aureus. Now, these bacteria can reach the bone through the bloodstream, they can sneak in from a nearby wound, or they can march right in through a nasty fracture. And once they set up camp there, oh boy, they become incredibly difficult to kick out. It's like a siege on the bone itself. Now look at this. This is fascinating. When an infection becomes chronic, the body does something really smart. It tries to wall it off. That central piece of dead infected bone you see, we call that the sequestrum, and then the body builds a shell of new living bone around it called the involucrum. It's a desperate attempt to contain the infection, like building a little jail. But the problem is, this bony fortress also prevents our antibiotics from getting inside to reach the enemy hiding there. And now, for a particularly devastating form of this disease, Pott's disease. This is tuberculosis of the spine. The infection spreads to the vertebrae, and it just eats away at the vertebral bodies and the discs in between. As you can see in this specimen, this destruction causes the spine to literally collapse, leading to severe deformities like a hunchback. And even worse, it can compress the spinal cord, leading to terrible neurological problems. Okay, for our final section today, we're moving to a topic that I know is often the most feared: bone tumors. This is what happens when the bone's own cells decide to rebel, to go rogue, and start growing in a completely uncontrolled, abnormal, and dangerous way. Before we look at examples, we have to understand the basic difference between benign and malignant tumors. Think of benign tumors as well-behaved. They're smaller, they have clear, well-defined borders, like a fence around a property, and they stay put. Malignant tumors, or sarcomas, are the total opposite. They are aggressive gangsters. They have irregular borders, they invade the surrounding tissue, and they have that deadly potential to metastasize, to spread to other parts of the body. Now let's see what this looks like on an X-ray. On the left, you see a benign osteochondroma. See how it grows so neatly outward from the bone on that well-defined stalk? It's contained. Now, look at the chaos on the right. That's an osteosarcoma. It's a destructive mass that is literally exploding through the bone. And do you see that little triangular shadow where the tumor has lifted the outer layer of bone? That's a Codman's triangle, a classic and very ominous sign of a highly aggressive cancer. And now we zoom in from the X-ray right down to the microscope. On the left, a benign tumor. The cells are orderly, interconnected, disciplined. But on the right, well, that is the cellular anarchy of osteosarcoma. The cells are a total mess, all different shapes and sizes, what we call pleomorphism, with large dark nuclei or hyperchromasia. And the bone they're making is just this abnormal, flimsy, lace-like material. This, right here, is what cancer looks like at the cellular level. So let's just quickly pull together those key metabolic ideas. Pay attention, this is important for your exams. Osteoporosis is a loss of bone quantity. There's just less bone. Osteomalacia is a quality problem. The bone is there, but it's soft and poorly mineralized. Remember that distinction. Then we have renal osteodystrophy, that whole mess that comes from kidney failure. And finally, Paget's disease, with that chaotic, disordered, but structurally weak bone. Understanding these differences is absolutely crucial. So this brings us to a final, bigger question to think about. We've seen today that our bones are not static pillars at all. They are dynamic battlegrounds, a constant microscopic war of creation, destruction, defense, and repair. So what does this constant battle, this delicate balance between order and chaos, happening deep within our own bones, what does it teach us about the very nature of health itself? It's a fascinating thing to consider.
Hello, everyone, and welcome. Think about it for a second. Our skeleton, this bony framework of ours, it's a real marvel, isn't it? It gives us our shape, lets us move around, but what happens when this very framework starts to break down from the inside? In today's class, we're going to dive deep into the world of bone tumors and joint diseases to really understand how these critical structures can sometimes become our biggest challenge. And that's the real question, isn't it? The one that's at the very heart of everything we're going to discuss today. I mean, our skeleton is supposed to be our support system. So what on earth happens when its own cells start to rebel, to grow completely out of control, or when our own body begins to attack our joints? That's the story we are going to explore.
Okay, to get started, just look at this. This is a cross-section of a bone, and you can see these massive, blood-filled spaces that have just completely hollowed it out. This is something we call an aneurysmal bone cyst. It's such a powerful image, and it really sets the stage for what can go wrong inside our bones. So let's begin our journey right here.
All right, let's start with the really bad guys, the malignant players, the truly aggressive cancers. First up, we have something called chondrosarcoma. Now, just break down the name with me. Chondro, that means cartilage, and sarcoma means a malignant tumor. So put it together, and you have a cancer that comes from the very cells that are supposed to build the cartilage cushioning our joints.
So this CT scan here, it shows us exactly what that looks like inside a patient's body. You see that big cloudy mass in the pelvic bone? A healthy bone should have a clean, sharp outer shell. We call it the cortex. But here, look, the tumor is just breaking right through it, invading all the surrounding muscle and tissue. This complete refusal to respect boundaries, that's a true hallmark of an aggressive cancer.
Now this slide, this tells the whole story, from the big picture to the tiny details. On the left, you see what the tumor looks like to the naked eye, lumpy, abnormal cartilage. But the real truth is on the right, under the microscope. Instead of neat, orderly cells, what we see is absolute chaos. The cells are all different shapes and sizes with these large, dark centers. This cellular anarchy, that is the very definition of cancer.
So the big question is, how dangerous is this thing? Well, it all comes down to its grade. You can think of it like a rating system for just how chaotic those cells are. A grade 1 tumor is more orderly, and thankfully it rarely spreads. But a grade 3? That's highly aggressive. It often travels to the lungs, and it can drastically lower the chances of survival. This grade is the most critical factor for a patient's outlook. You must remember that.
Okay, our next example is another very aggressive bone cancer, called Ewing sarcoma. But what makes this one particularly tragic is who it affects the most, children and teenagers.
And this number, well, it really drives that point home. Around 80% of all patients who are diagnosed with Ewing sarcoma are younger than 20. It is, fundamentally, a cancer of the young. It's just devastating. When you look at an X-ray, Ewing sarcoma often creates this very distinct pattern that we call an onion skin reaction. See, as the tumor grows from the inside of the bone, it pushes outwards, and it irritates the bone's outer lining. So what does the body do? In response, that lining creates new, thin layers of bone, one after another, and it ends up looking just like the layers of an onion. And then when we look through the microscope, we find the tumor's signature look. You get these dense sheets of small, uniform, round cells that stain a deep blue. The appearance is so characteristic that pathologists actually group it with other childhood cancers known simply as small, round blue cell tumors. This distinct pattern is a major clue for the diagnosis.
So what's causing all this chaos? It's incredible, but in over 90% of cases, it all comes down to one single genetic mistake. A tiny piece of chromosome 22 breaks off and wrongly attaches itself to chromosome 11. This little mashup creates a faulty new gene, which then produces a rogue protein. And this protein, it hijacks the cell's controls and just drives the cancer. It's such a powerful example of how one tiny mistake can cause such a massive problem.
Okay, so up until now, we've been looking at malignant or cancerous tumors. But not all growths inside the bone are cancerous. Now, let's look at a few examples of benign tumors. And as you'll see, benign does not always mean harmless. A perfect example of this is the giant cell tumor. On the X-ray on the left, you can see how it has just eaten away a large cavity at the end of the bone, right there near the knee joint. And it gets its name from what we see under the microscope on the right. These huge, sprawling cells with many nuclei inside them. So while it's not a cancer that's going to spread through the body, you can see just how destructive it can be right where it grows. And this brings us right back full circle to that very first image we started with, the aneurysmal bone cyst. This is another benign growth, not a cancer. It's caused by a specific genetic mix-up that creates these large, blood-filled cavities that essentially eat away the bone from the inside. And even though it's not cancer, it's easy to see how this can dangerously weaken a bone, making it very likely to fracture. All right, so far we've been focused on tumors growing inside the bone. But what about the places where bones meet, our joints? So now we're going to shift our focus and explore arthritis, a group of conditions that affects millions and millions of people all over the world. Let's start with the most common type, something I'm sure you've all heard of, osteoarthritis. And really, this image tells the entire story. The protective cartilage that covers the ends of our bones, it should be perfectly smooth, like polished glass. But look here, you can see it's become frayed, cracked, and just completely worn down. At its very core, this is a disease of mechanical wear and tear.
Now, this table is really important because it shows the crucial differences between the two main types of arthritis. And the single biggest takeaway, the one thing you must understand, is the root cause. Osteoarthritis is a mechanical problem. The cartilage physically wears down over time. But rheumatoid arthritis? That's an autoimmune problem, where the body's own immune system mistakenly attacks the lining of the joints. This one fundamental difference, it explains everything else you see on this chart.
In rheumatoid arthritis, there's a key destructive force that has a very specific name you need to know: pannus. Now, this is not just simple inflammation. I want you to think of it as an aggressive, invasive tissue. It's made of inflammatory cells, and it grows over the joint cartilage like a destructive blanket, actively eating it away.
And here is a look at that very battlefield, under the microscope. This is the joint lining in a person with RA. Instead of a thin, smooth layer, it's become thick and folded, and it is absolutely packed with immune cells. These are the soldiers of the autoimmune army. This is where the pannus begins to form, right before it launches its attack on the cartilage.
Okay, we have covered a lot of ground today, from aggressive bone cancers all the way to chronic joint diseases. So let's take a moment and quickly recap the biggest takeaways from all of this.
So what are the key points you need to walk away with? First, malignant bone tumors like chondrosarcoma and Ewing sarcoma often trace back to specific cell types and even specific genetic mistakes. Second, remember that benign tumors are not cancerous, but they can still be very destructive right where they grow. And for arthritis, the core difference is simple. Osteoarthritis is a wear and tear problem. Rheumatoid arthritis is an autoimmune attack. That is the most important distinction you need to remember.
And it's probably worth ending with this thought. You see, understanding these diseases isn't just about putting a name to them. It's about digging deeper to understand the why. Why does a specific gene go wrong? Why does the immune system turn on itself? Because only by answering the why can we ever truly hope to figure out the how to cure them?
And this, of course, leads us to the biggest challenge for the future. As we continue to unlock the genetic secrets behind these conditions, the big question becomes this: will we one day be able to develop personalized therapies that can stop these diseases before they even have a chance to start? That is the hope that we are all working towards. Thank you for your attention. All right, everyone, settle down now. Good morning, good morning. So today we are going to dive into a really fascinating and, I must say, very important topic. What happens when things go wrong inside our joints and soft tissues? Now, you must pay close attention, okay? Because this stuff, it's not just to pass your exams beta, this is for your entire clinical career. You will see these patients. So, let's begin, shall we?
Okay, first things first, let's start with a bit of a clinical puzzle. Just look at this image here. Look at these hands. I mean, they're telling a story, aren't they? A very painful story of deformity, of destruction. So what on earth, what disease process could do this to a person's joints? I want you to just keep this picture in your mind as we go through today's lecture, because I promise you, by the end of our session, you will know exactly what pathology is behind this.
Chalo, let's jump into our first major topic. We're going to compare the two giants of joint pain: osteoarthritis versus rheumatoid arthritis. Now you see, on the surface, a patient comes to you, they say, "Doctor, my joint is paining." It sounds similar, no? But what is happening inside that joint? Ho, that is two completely different stories. It's a completely different kind of battle being fought in there.
So let's get down to the morphology. Let's look closely. With osteoarthritis, I want you to think of it as simple mechanical wear and tear. That's it. You know, like an old machine just breaking down over time. The cartilage gets thin, it gets frayed, and the body tries to repair itself, but it does a bad job. It creates these bony spurs. We call them osteophytes. But now, look at rheumatoid arthritis. Oh, this is a different beast altogether. This is not wear and tear. This is an active attack. You have this thing called an inflammatory pannus. Just imagine a thick, angry sheet of tissue that grows into the joint and literally starts eating away at the cartilage in the bone. It is a war from within.
And this brings us to the most crucial point. You have to understand this. Osteoarthritis, OA, it's a local problem. It's one joint, maybe a few, getting worn out. The inflammation is just a side effect of the damage. But RA, rheumatoid arthritis, that is a systemic autoimmune disease. The inflammation is the main problem, the primary cause of all the destruction. And because it's systemic, it's not just in the joints. No, it can go after the lungs, the heart, the blood vessels, other organs too. This is a fundamental difference, and you must never, ever forget it.
Okay, so we've seen the body's own immune system attacking the joints in RA. But what if the attacker isn't our own cells? What if it's something microscopic, something sharp, something crystalline that starts forming right inside the joint space itself? Well, welcome, Bacho, to the incredibly, excruciatingly painful world of gout and its cousin, pseudo-gout. So how does a gout attack actually happen? It's a classic chain reaction, step by step. First, you have too much uric acid in the blood. We call this hyperuricemia. Then, what happens? This excess uric acid has nowhere to go, so it starts to precipitate. It forms these tiny, sharp, needle-like crystals right inside the joint. Now your immune cells, especially the neutrophils, they're patrolling around and they see these sharp little needles. They think, hey, foreign invader, and they attack. This attack releases a huge storm of inflammatory molecules, which calls in more neutrophils, which causes more inflammation. It's a vicious cycle that leads to that terrible acute pain. And if these attacks keep happening over and over time, look at what you get. These uric crystals, they start to build up. They form these large, chalky, whitish deposits that we call tophi. A single one is a tophus. These things are the absolute hallmark, the defining sign of chronic gout. And you can see it here, this big lump of crystals just surrounded by an army of inflammatory cells. Now let's go to the microscope. Let's look at the evidence right from the battlefield. What we're seeing here is synovial fluid taken from the joint of a patient who's having an acute gout attack. You see those cells there? Those are our neutrophil soldiers. And if you look really closely, you can see inside them. You can see the enemy, those slender, needle-shaped urate crystals that they've swallowed up. This process, this eating of the crystal, is called phagocytosis, and that is the trigger for the whole massive inflammatory explosion. So in the lab, how do we confirm this diagnosis 100%? We use a special trick. We use a microscope with polarized light. Now, you don't need to worry about the physics, but these monosodium urate crystals have a special property called negative birefringence. What does that mean for you, for the exam, for the clinic? It means something very simple. When the crystals are parallel to the light axis, they shine a bright, unmistakable yellow. That's it. That is your definitive diagnosis. You see yellow needles, you say gout.
Okay, everyone, eyes on the screen. Pen down for a moment. This is a VVIP slide for your exams. This is the classic comparison you will be asked about again and again. So, gout, needle-shaped crystals, monosodium urate, and they are negatively birefringent, which means they are yellow. Pseudogout, rhomboid-shaped crystals, calcium pyrophosphate, and they are positively birefringent, meaning they are blue. Just remember this. Needle is yellow, rhomboid is blue. Gout is yellow, pseudogout is blue. You must remember this.
All right, let's shift gears completely now. We've talked about unwanted inflammation, we've talked about unwanted crystals causing all sorts of havoc. So now, let's discuss the ultimate unwanted guest in our body's tissues: unwanted growth. We're moving into the world of neoplasia, specifically soft tissue tumors. And here, the fundamental question, the first question we always ask in oncology, is a simple one. Is it benign or is it malignant?
You know, they say a picture is worth 1,000 words, and this slide proves it. Look on the left. That's a benign lipoma. See how the fat cells look? They're plump, they're mature, they're well organized, they almost look like normal fat. They are behaving themselves, you could say. Now, look to the right. That's a myxoid liposarcoma. It's just chaos, absolute chaos. The cells are primitive, they're all over the place, disorganized, sitting in this weird, slimy, myxoid background. This visual, this is the very essence of the difference between benign and malignant.
So we're saying liposarcoma. What does that sarcoma part actually mean? Well, a sarcoma is a malignant cancer, a cancer that comes from what we call mesenchymal tissue. So think of your connective tissues: fat, muscle, fibrous tissue, bone. That's very different from a carcinoma, which you hear about all the time. Carcinomas come from epithelial cells, the lining cells of organs or the skin. Sarcomas are much rarer, but you have to know they can be very, very aggressive.
And look, in modern pathology today, it's not enough to just look at cells under a microscope anymore. We have to go deeper. We have to look at their genes. And what we find is that different subtypes of liposarcoma have their own specific genetic fingerprint. For example, the well-differentiated type, it has extra copies and amplification of a gene called MDM2. The myxoid type has a very specific chromosomal mix-up, a translocation. And the pleomorphic type, well, it's just a genetic mess, a total chaos. And knowing these genetic markers is absolutely crucial not just for an accurate diagnosis, but for developing the targeted therapies of the future.
Okay, class, we have covered a lot of ground today, haven't we? From joints to tumors. So now it's time to summarize everything. This is the high-yield stuff. These are the facts that you absolutely must take away from this lecture and carry with you, not just for the exam, but into your clinics.
All right, let's do a quick rapid-fire review. Are you ready? Okay, rheumatoid arthritis. What is it? Autoimmune, systemic, pannus. Good. Osteoarthritis, degenerative, mechanical, wear and tear. Gout, painful inflammation caused by those needle-shaped urate crystals. Lipoma, super common, benign tumor of mature fat. And finally, liposarcoma, malignant tumor of fat, and remember the subtypes are defined by specific genetic changes. You got all that? Excellent.
And let's just end with this one thought. Today, we've only explored a few of the incredible battles happening at the microscopic level inside all of us. You have attacks from your own immune system, attacks from tiny crystals, attacks from rogue cells growing out of control. It really makes you wonder, doesn't it? What other silent wars are being fought inside our bodies right now, this very moment, that we still know so little about? That is what pathology is all about. Something for you to think about. Thank you, everyone. We'll see you next time.
Welcome back, everyone. Today, we're going to take a closer look at the world of soft tissue tumors. We'll be diving right into the microscopy, looking at what really defines these growths. So, let's get started.
So this is our plan for today. We're going to follow a very logical path. We'll start with the benign tumors, then move on to their evil twins, the malignant ones. After that, we'll tackle some really puzzling tumors, and then we will wrap it all up with a summary. Cello, let's begin.
Right, so we're starting with a very common and thankfully a pretty straightforward case. This is a benign smooth muscle tumor called a leiomyoma, and trust me, you will see this again and again in your clinical practice.
So what exactly is it? Well, simply put, it's a benign tumor of smooth muscle.
That means it's non-cancerous. Its most common home is the uterus, where you've probably heard it called a fibroid. But you have to remember, it can technically pop up in any soft tissue site.
Now, under the microscope, what's really striking is how orderly it is. Deco, the cells are all arranged in these neat little bundles or fascicles. They stain pink, which we call eosinophilic. And here are the most crucial points. You see minimal atypia, which means the cells look pretty normal, and very few mitotic figures. That tells us the cells are not dividing like crazy. It's benign. A simple excision, and it's usually gone for good.
Okay, so let's move on and see what happens when things take a turn for the worse. Now we are getting into the serious stuff. This is its malignant counterpart, a much more dangerous tumor, the leiomyosarcoma. I want you to pay very close attention to the differences.
The contrast here is absolutely critical. This is a PACA exam question. I guarantee it. Just look at the key differences. We go from orderly bundles to messy, interweaving ones. From normal-looking cells to ones with dark hyperchromatic nuclei. And from very few mitotic figures to what we call brisk mitotic activity. And of course, the prognosis, it goes from excellent to potentially fatal. So, just look at this description. Interweaving fascicles, brisk mitotic activity, and necrosis. These are the classic textbook signs of malignancy we are always looking out for. The moment you see necrosis, actual tissue death, you have to suspect something very aggressive is going on.
Clinically, you have to understand that location is everything. This is a very important point for you as future doctors. A superficial leiomyosarcoma, one just under the skin, it's manageable. The prognosis is good. But one that's hidden deep inside the retroperitoneum, that is a major challenge. Why? Because they grow very large before anyone finds them, and often they're impossible to remove completely.
All right, now for the truly fascinating part of pathology, what I personally find most interesting. What happens when you look down a microscope and you find a tumor that doesn't look like any normal tissue? All right, what do you do then? This is where the real detective work begins.
This is the puzzle we're facing, huh? These tumors force us to rely on other clues. We can't just look at the morphology, the shape and the structure of the cells, and say, aha, that's smooth muscle. We have to pull out other tools, like genetics, to figure out what we're dealing with.
Okay, first up is synovial sarcoma. Now please remember this. The name is historical, and it is a complete misnomer. It is misleading. It does not come from the synovium of the joints. This is a classic exam question just designed to trick you. It can show up in places that have no synovium at all.
So if the cell structure is confusing, what's the clue? It's genetic. There's this unique chromosomal translocation, TX18, where parts of the X and 18th chromosomes basically swap places. This is the genetic fingerprint of this sarcoma. If you find this, you have your diagnosis. Histologically, it can also appear in two patterns, monophasic or biphasic. And here you can see what we mean by the biphasic pattern. Biphasic just means two phases, or two types of cells. You can actually see them living side by side here. The long, thin spindle cells, which look a bit like connective tissue, and then these gland-like structures, which look more like lining tissue. This strange mix is very characteristic.
Let's move to our final case for the day. Now, this one is, well, it's a sort of wastebasket category. When we've looked at everything else and nothing fits, this is where it ends up. It's for the most aggressive and unclassifiable sarcomas.
This is what we call a diagnosis of exclusion. So when a sarcoma is clearly malignant, clearly aggressive, but it doesn't fit into any other box. It's not a liposarcoma, not a leiomyosarcoma, nothing we can define. It falls into this category.
Just look at this slide. It is complete and utter cellular chaos. There is no order whatsoever. You can see these huge, bizarre anaplastic cells. The nuclei are hyperchromatic, they're irregular, some of them are just plain weird-looking. There is absolutely no organized structure. This is the face of a highly aggressive, high-grade cancer.
And all of this chaos translates to a very poor prognosis. The really crucial point to remember is that up to half of these cases will metastasize. 50%. That is an incredibly high rate, which makes this a very dangerous tumor.
All right, let's summarize. Pay attention now. These are the key concepts from today's lecture that you absolutely must remember, not just for your exams, but for your entire clinical career. Okay, let's lock these points in. First, sarcomas come from primitive mesenchymal stem cells, not from mature tissue.
Second, some tumors, like our leiomyoma, will try to mimic that mature tissue. Third, others, like synovial sarcoma, have no normal counterpart at all. And finally, remember that the genetic complexity, what we call the karyotype, often goes hand in hand with the prognosis. Simple genetics usually means a better outlook. Complex, messy genetics, well, that often means a much poorer one.
And I'll leave you with this final thought. If these cancers are coming from such basic, pluripotent stem cells, cells that have the potential to become many different things, then does the real key to treatment lie in stem cell biology itself? Think about it. Maybe the future isn't just about killing cancer cells, but about controlling how these stem cells behave. We'll explore that next time. Class dismissed.